A 90-year-old female presents with retrosternal chest pain and dysphagia. I am showing you barium esophagograms. Describe the findings.
Okay, looking at the images, the esophograms demonstrate multiple simultaneous non-peristaltic contractions in the distal two-thirds of the esophagus. These contractions temporarily segment the barium column, creating a classic corkscrew or rosary bead configuration.
What is your primary diagnosis?
Based on that, this represents diffuse esophageal spasm, also known as distal esophageal spasm.
Explain the classic radiographic descriptor associated with this condition on barium studies.
It is classically described as a corkscrew esophagus or rosary bead esophagus, reflecting the segmentation of the barium by simultaneous tertiary contractions.
What is the underlying pathophysiology believed to cause diffuse esophageal spasm?
Based on that, it is thought to result from a dysfunction or loss of inhibitory nitric oxide-producing ganglion cells in the distal esophageal wall, causing premature and hyperactive muscular contractions.
What is the clinical presentation of this condition, and what mimics must be ruled out?
So, patients present with intermittent retrosternal chest pain and dysphagia to both solids and liquids. The chest pain can mimic cardiac angina, which must be ruled out first.
What is the gold standard diagnostic test to confirm diffuse esophageal spasm, and what are the specific criteria?
So, high-resolution manometry is the gold standard. According to the Chicago classification, it is diagnosed when at least 20% of test swallows demonstrate premature contractions with a distal latency of less than 4.5 seconds in the presence of normal lower esophageal sphincter relaxation.
How do you distinguish diffuse esophageal spasm from presbyesophagus on imaging?
Presbyesophagus represents age-related motility changes characterized by low-amplitude, non-propulsive contractions that are generally asymptomatic and do not cause significant chest pain, whereas diffuse esophageal spasm features high-amplitude, painful, lumen-effacing contractions.
How does diffuse esophageal spasm differ from jackhammer esophagus on manometry?
Based on that, jackhammer, or hypercontractile, esophagus is characterized by coordinated peristaltic contractions that are extremely high pressure, whereas diffuse esophageal spasm is characterized by simultaneous, uncoordinated, and premature contractions.
How would you manage this patient as a radiologist?
Based on that, I would communicate the findings to the referring clinician. I would recommend referring the patient to gastroenterology for high-resolution manometry to definitively classify the motility disorder and an upper endoscopy to rule out any mechanical obstruction or mucosal disease.
If the patient were a surgical candidate, what intervention might be discussed in a multidisciplinary team meeting?
In a multidisciplinary team setting, for severe refractory cases, we would discuss endoscopic botulinum toxin injection or referring the patient for a long surgical myotomy extending into the proximal esophagus.